This unit and the last one, we're going to be talking about medical conditions that can be treated by autonomic drugs. Specifically, this is a way for you to kind of test yourself to see, whether you recall the subtypes of the drugs, the receptors that are affected, whether there's agonists or antagonists that might be more logical in that circumstance. And in this unit, we're going to talk about cardiovascular disease. In the second unit, we'll be talking about other conditions. Let's start with looking at cardiac disease. And I think I'm listing on the left the conditions and the types of drugs. Most of these we're going to tell you when they're an agonist or an antagonist. But realize that what we're managing are there's a muscarinic receptor on the SA node, and we have a beta 1 receptor on the SA node. And these are the major inputs into the heart with regards to the autonomic nervous system. So when we have a condition that leads to lower heart rate, bradycardia, how can we increase the heart rate? Well, you probably kind of know this, that epinephrine is meant to be released to result in the increase of the heart rate physiologically. This is something that you might do, but notice epinephrine has effects, yes, on beta 1, but also on alpha 1 and beta 2. The drug isoproterenol is actually designed to be a beta 1, beta 2 agonist, but we have some issues with its use in terms of it not being sometimes specific enough. We also can increase heart rate by blocking the muscarinic receptor with a drug like atropine or other drugs. And I'd note that this is sometimes done almost in a diagnostic manner to see if there's some vagal influence on the lowering of the heart rate. And sometimes it's even done prospectively, or I should say prophylactically, to reduce the tendency for preoperatively, for example, for the heart rate to be depressed during manipulation, let's say, of the viscera during a surgery. What about the other situation? What about a tachycardia? In most cases, let's focus on supraventricular tachycardia, or one that really arises somewhere between the SA node and the AV node. And so, obviously, the opposite situation. You want to use a beta 1 antagonist, and our prototype here is atenolol. This is useful to do. And amongst other treatments that are not autonomic, this is the one that probably makes most physiological sense. What about congestive heart failure or cardiac arrest or cardiogenic shock? Again, if we have a reason that the heart's pumping abilities have failed, then we might want to stimulate this beta 1 receptor. And the drugs that we do this with, I'm listing here, is dobutamine is a specific beta 1 agonist. So it's an agonist. And dopamine has dopamine activity, so basically dopamine 1, dopamine 2, and it has beta 1 and alpha 1 activity. So dopamine could do this, or epinephrine. And epinephrine, as we pointed out before, has basically really dominantly alpha 1, beta 1, and beta 2. What about hypertrophic cardiomyopathy? So the situation where you have gross enlargement and thickening of the ventricles. And so this is a chronic condition, something we see predominantly in cats. Well, we use beta 1 antagonists in this situation, and atenolol, with the idea that there's some autonomic component that originally initiated the problem, and or the ability to take these very stiff hearts and slow them down and allow them to function and lead to greater beat-to-beat cardiac output by slowing the heart rate, that's beneficial. This is also being used in hyperthyroid or thyrotoxic cardiomyopathy as well. And that's called thyrotoxic cardiomyopathy. What about vascular disease? And let's remind ourselves of what we've got here. Well, we do have muscarinic receptors, and we have dominantly in the major vessels, we have the alpha-1 adrenergic receptors. So you're going to see the theme comes up over and over again that what we're really trying to target are these alpha-1 receptors. Except in the renal blood flow, in the renal vessels, I should say, the arteries, we have dopamine 1 receptors. So what about hypotension? Hypotensive situation, animal needs something to increase its blood pressure. Well, alpha-1 agonist, a specific alpha-1 agonist, and these I've just listed for you, and these are not the focus of this. We really want you to understand the logic behind the reason for using a drug class, or why you want to stimulate that receptor, and we just want you to know there are drugs that do that. You can also increase the cardiac output by using dobutamine, beta-1 agonist. And you'll also, because of its sort of being a neurotransmitter, as I mentioned before, dopamine affects not only dopamine 1, 2 receptors, but also alpha-1 and beta-1 receptors. And so by stimulating particularly the alpha-1 and beta-1, we can increase cardiac output and also increase peripheral vascular resistance. What about the condition of hypotension and anaphylaxis? So this is a situation where you have a very specific treatment of epinephrine. And basically, the reason for this is that mast cell degranulation, which is associated with this, can be actually shut down by the alpha-1 receptor. But also, with the hypotension, you're stimulating and increasing blood pressure. You're leading to bronchodilation if the animal has got bronchoconstriction as a problem. So there's a number of reasons why it's indicated to use epinephrine specifically in anaphylaxis. We also see epinephrine being used, obviously, as a local constrictor agent added to local anesthetics. We want to maintain them in a certain region where we want to restrict those blood vessels, and epinephrine through the alpha-1 receptor will do that. We also find epinephrine put in, sometimes packed into the nasal cavity, can help to reduce not only the blood flow but also the secretions, because alpha-1 is reduction of secretions and congestion. Neosynephrine is the nose drops that you might take that also has an alpha-1 activity. Phenylephrine, same effect. We talked a little bit about what happens in acute renal failure and the logic for using a dopamine 1 agonist. And that very specifically is dopamine. And I've listed for you here the receptor affinity being shown from left to right as being highest, meaning tightest, meaning the lowest concentration works for dopamine. But as you start to, as you administer this, and you have to administer dopamine by a drip, you might find that as you get above a certain level, your toxicity would lead to tachycardia. And that's not one reason you monitor dopamine with an ECG. And then finally, even if you lead to renal blood vessel dilation, at some point, if you use too high a dose, you're going to get to that alpha, that should be alpha-1 receptor effect, and that's going to lead to vasoconstriction, and that will shut off blood flow to the kidneys, arteries. They'll become less relevant. So you kind of work against your original benefit of just dilating specifically the renal blood flow. And what about managing hypertension? We do see usually secondary hypertensions in animals. Well, we use alpha-1 antagonists like prazosin for hypertension, and we use beta-1 antagonists like atenolol or isoproterenol to manage hypertension. And this is the use of these drugs are extremely common in human medicine, where essential hypertension is much more common than in animals. Finally, I want to use a very specific phenomenon that we see in clinical medicine that's called the phenomenon of epinephrine reversal. And we're going to use this as a sort of a final exam, a reason for understanding where the receptors are, how they work, and understand the difference between agonism and competitive antagonism. Generally, we see this phenomenon when we use non-selective alpha antagonists. So I'm going to ask you to start with saying, okay, what does that mean? That means it's an alpha-1/alpha-2 antagonist. Let's keep track of our receptors. And then what you find is the animal, if they have a low blood pressure response, clinician might say, hey, I need to stimulate this blood pressure, I'm going to give epinephrine. And so normally epinephrine would be a pressor. It does have alpha-1 activity. It would then lead to eventual overwhelm. These are still reversible, so we can overwhelm it with a high concentration of a drug like epinephrine. The problem is it actually leads to a hypotensive effect, and this is due to beta-2 receptor-mediated vasodilation. And so, again, and this is just a specific example of a very general thing you should do, is to check your receptors. So we've given an alpha-1, alpha-2 antagonist, and we've got a problem. And so now we come along with a drug that can stimulate basically for all four receptors, because epinephrine and most of the endogenous neurotransmitters, even norepinephrine, are fairly non-specific in terms of which receptor subtypes they hit. So what happens is, and I just do the math, you take out these and you end up with these, and this is the net effect of the two. You will get an increased heart rate. Fix that. You'll get an increased heart rate, and to some extent contractility will improve, but you get the peripheral vascular beds will lead to a vasodilation due to the beta-2 receptor activity. So what's the solution here? The solution is that you should just give an alpha-1 agonist. So you could give a drug that, you don't need to know this, but say something like methoxamine or phenylephrine, something that targets only the alpha-1 receptors, so it can target that blood pressure problem and push the antagonist off of the receptor. So as I said, we see this with phenothiazine tranquilizers. We see it with some antihistamines that basically have phenothiazine activity. And so in general, in sort of summary, to the entire autonomic nervous system, it's all about integration. It's all about understanding that at the cellular level, but particularly at the tissue level, for a clinician to basically sort out why do we use this drug versus another drug. And I think now if you go back and look at the table that we gave you in the first unit, you might get a better picture for how you could use this table anytime you give a drug and say, hey, I think this drug is going to have this beneficial effect on this tissue. And say, oh, but wait a minute, there's a similar receptor in that tissue. Is that going to be a problem? And sometimes that actually predicts side effects. And so beware.